David, I just spoke with him and he said he never received the link, so I just forwarded him what you sent to me.
Oh dear. He confirmed it last week.
He said he emailed you this morning, but that's okay. I sent it, so let's see if he can get in.
Wow. Okay.
Picture was there and then it disappeared. I don't know how to get it back.
There he is, right there.
There he is. Okay. Hi, Dr. Mantz.
Hi, Linda. Hi, everyone. I'm sorry I'm a minute late, 2 minutes late.
Dr. Mantz, David Morse here. I apologize for some apparent screw up on the invitation to you.
No, listen, don't worry, David. I'm happy to join the call, and it's by far the least screw up I've had all day. So, you know, not a problem. Not a problem on my end. So.
Well, why don't we get started with, it is 2 o'clock and any delay in the start today is basically my fault, so I accept all the blame, but nonetheless, we've got a lot of very interesting information to deal with today. Dr. Constantine Mantz is greeting us from the Fort Myers area, actually Fort Charlotte, I believe, right? Or,
Fort Myers.
Yeah. Fort Myers, yeah. And he is with Genesis Care. His medical history comes from the University of Chicago and University of Chicago Hospital. And he is the person for us to be talking to about PSMA scans. To me, this is a revolutionary, very new, very exciting prospect for all of us, regardless of our status with our prostate cancer. And I think it's so new that I'm not very familiar with it, and I know a lot of us have had many questions to ask about the process. So, Dr. Mantz, if you don't mind kicking it off with comments from you, and then if you'll answer some questions from the guys, I'm sure there will be many.
No, happy to. And so, just by way of introduction, I'm a radiation oncologist, and have been in practice now for a little more than 20 years. I also served my company as its chief policy officer, previously as its chief medical officer. And in those roles, some of my responsibilities include identifying and integrating into our network new technologies as they have to do with the treatment and diagnosis of cancer patients. And PSMA is the latest such improvement that we've identified and have brought into the company. We have been now the first practice that offers PSMA imaging on the west coast of Florida as of about a couple of months ago. We started imaging patients with PSMA on the East Coast in one of our other facilities about 4 months ago. And just to note that the FDA granted its approval for PSMA only in late May. And so we're very happy that we were able to step on the gas and be first to market with this imaging technology. And I've got a formal presentation if the group would like to go through it. But I'm happy to answer any questions, at least right at the start here, if anyone has, a high order type of concern that maybe we could address first.
Real quick, how are you, Doctor? I appreciate having the opportunity to talk to you. And in August, I received the maximum scan, which I believe the PSMA test was not available. As a matter of fact, I do go to one of the physicians that's part of your Genesis group, and he recommended at that point, he felt that was the best test available. And the outcome was basically they couldn't find I had radiation 3 years ago, but my PSA started going back up and went from 0.2 to 0.4, 1.5, 1.6, and 3.6. At that point, he said, well, we got to do these scans. But anyway, so, and found no cancer in the prostate, but had two microscopic findings in two lymph nodes in the pelvic area. So my question is, would it be beneficial? At this point, I'm on hormone treatment and some other pill called Erliata, and 4 pills a day, 240 milligrams. But at one point, would it be feasible to have another scan to see if my treatment works? Because certainly my concern is, since obviously it moved outside the prostate. So, there's obviously at this point, what he felt is, I cannot have no more radiation. I can only have this particular treatment, which I'm on now for the time being, until he sees what process we will make. And he felt pretty confident that my PSA level should come way down, and as well as my testosterone level. So
I can't go to setup. Hit setup. No.
hello?
What happened now?
So we'll
So
wait.
my-
So
my-
Mr. Perkow, I think then your question is one, is there value in obtaining a PSMA scan now that you've had the Axeman scan and you've
Right.
already indicated treatment for it? And the question that I would also ask in follow up to that, if not now, then when? And so and to back up for a moment, in the near future, PSMA imaging will largely replace Axeman scanning. At the present time, Axeman is the gold standard of care, that it's widely available and is superior to other types of imaging for the detection of prostate cancer outside the prostate. This gradually over the next year to year and a half will supplant that. And most facilities, if not almost all of them, will be able to do PSMA scanning. But we have this window now in between those times when a few centers can do it, and what patients should be seeking out a PSMA scan. I think as Axeman identified some evidence of activity in the lymph nodes, that PSMA scanning at most would repeat the same findings, that it may not add in a meaningful way, I think in your case, to a decision for how to treat this recurrent prostate cancer. And if the lymph glands are involved, then the hormone therapy that you're receiving is appropriate care and will temporize progression of this prostate cancer for an indefinite period of time. At some point in the future, who knows when, if it's 5 years from now or some other time, if the hormone therapy is no longer effective at controlling PSA, at that point, a PSMA scan, unless there's something better that is developed between now and then, which doesn't seem to be on the horizon, would be the test to order in order to identify where in the body is there a source of resistant prostate cancer making PSA. That's not right now, and it won't be that for, we hope many years, for years. But for the time being, Arno, I think,
You were cutting out. I missed the last comment.
Yeah, but for the time being, I think your management with hormone therapy and the Erlidia that's being used to supplement the hormone shot, if I were to order a PSMA scan for you, I probably would not change your management. I think that would remain exactly the same.
Okay.
Yeah.
Well,
I would
I appreciate.
Yeah, there would be value in repeating the scan only if we believe that there's an opportunity to change management to the patient's benefit. Yeah.
Okay.
Yeah.
Okay, well, thank you very much. It makes me feel a lot better that I know I'm on the right track. I just, in about 3-4 weeks, I'll have my first follow-up PSA test, the testosterone and so forth. So hopefully it'll show up with a significant improvement so that I really have the confidence we are on the right track. So obviously, I have big concern about it. So to make sure, since I can no longer have radiation, that like I said, I have, it's concerning. And then because, the stuff is in you, and is this treatment really the gold standard? I think I've asked that before, but I really appreciate you confirming it. So now I can sleep a lot better.
No,
And,
you're welcome. So I'll make an easy prediction now. Your PSA will plummet with your next test. So you'll see that. You'll see.
Okay, thank you very much.
Yes, sir. Other questions before we?
Can you give us a little bit of background about exactly what PSMA is? I'm not certain about all the difference between that scan and any other kind of scan one might receive. Can you give us a little background on that?
Yeah, I mean, so the critical difference, and we can go through the slides and show it graphically too, but the critical difference is that PSMA utilizes a protein called prostate-specific membrane antigen, and that's what forms the acronym PSMA. Is a specific protein that almost exclusively is produced by prostate cells. And prostate cancer cells will produce this protein in excess. It's a protein that forms on the very surface of the cancer cell and serves as a target for an imaging agent, such as a PSMA scan, to bind to that specific protein and produce a signal that can be detected on film or by computer that will give the physician an idea of where there may be a collection of active prostate cancer cells. All other previous imaging tools have used surrogates, but not direct targets for prostate cancer cells. And without getting into all the painful chemistry and biology of it, that what PSMA has been able to develop is a smart bomb that targets specifically something that is almost exclusively produced by prostate cells and would bind to it and then image it to demonstrate very clearly where there is a collection of prostate cancer activity. PET scans are part of PSMA scanning, as Axamin and PET scans are combined together. To make the distinction here, PSMA is the solution that is injected into the patient, and the PET scanner is the piece of hardware that images where the PSMA collects in the body and produces three-dimensional information for the physician to use to determine where there might be cancer present.
Does it focus on concentration, or just check and see if it's spread outside of the prostate itself?
Right, and so anywhere where there may be prostate cancer cells, whether the prostate cells are present just in the prostate, or if they've broken free and have traveled to lymph glands or have traveled through the circulation to more distant sites, usually the skeleton, that the PSMA solution does not discriminate. It only looks for prostate cancer cells wherever they may be in the body. And so it's a very useful tool for scanning the person from top to bottom and trying to identify where the source of excess PSA may be. And
when you inject this solution, you go into a full body scan. Is that how it's read?
That's right. It's a nearly full body scan. I mean, the imaging starts above the ears and extends down to just above the knees. And so, but if the doctor should request, the person may also be imaged head to toe. There's a standard PET scan that covers, about 70% of the man's territory, but it could be made 100% upon physician request. If we expect that there's an unusual metastasis below the knees, or then we would make that request to the radiologist. But to keep it straightforward, let's just presume it's a full body scan. Yeah.
Well, what is the solution that they use? Is it a protein solution, or?
Yeah, and so the solution itself is a molecule that will bind very selectively and with a high degree of fidelity to this PSMA protein that's present on the cell surface of prostate cancer cells. And attached to this molecule is a radioactive element that produces the signal. So the way that it works is that the stuff is injected as a solution into the patient and then is allowed to circulate throughout the body for about a half hour or so that there's sufficient time for broad distribution of this. And over that period of time, the molecule in the solution will find PSMA wherever it is in the body and bind to it. And the radioactive element that's bound to the molecule will then produce a signal, a gamma ray. And that gamma ray is detected by hardware that's built into the PET scanner. That imaging data is then translated into a picture of the patient. And any areas that have collected this solution in excess will light up as bright dots on a film. And we'll show some images here in a moment.
Dr. Mantz, how long does the procedure take?
So we tell our patients to expect about an hour to an hour 15 minutes total time from getting the injection to allowing some time for the solution to circulate and distribute to needing to spend about a half hour or so to get the PET scan done, the imaging part of the study. So about an hour or so.
Thank you.
Yes.
Are there any residual effects with the solution? How long does it take to dissipate?
Yeah, and so it clears from the body rapidly. So within a matter of hours, it's the radioactivity has dissipated to background levels, and the molecule has broken down. And so we'll tell patients that as they exit the facility that they don't really have any specific radioactive precautions that they have to take around family members and others. We'll also scan patients and compare any radioactive levels that we detect against background levels, just to make sure that there isn't any unusual excess activity before we discharge patients to home.
Dr. David Kaczynski has a question for you.
Okay, David.
Doctor, is PSMA scanning offered in the Sarasota area at any of the Genesis locations, or is it closest one Fort Myers?
No, right. The only site on the West Coast now is Fort Myers. And so it's not yet available in Tampa or further north. It's just my local labs.
Okay, thank you.
Yep.
You may have already covered this, but does insurance cover this?
Yeah, and so we've had Medicare, Blue Cross Blue Shield, United, Cigna, cover these procedures. To date, the insurance that we've had any meaningful trouble has been Humana. But we've scanned patients with almost every other type of insurance coverage, and have not had meaningful pushback.
And they cover both the procedure and the injection infusion.
Yeah, right. That the PET scan part has a procedure code that's been on the books for many years, and that's covered, provided that you provide an appropriate clinical indication. A man with history of prostate cancer, previously treated with a rising PSA, for example. The solution part of it is covered separately as a supply, and without getting into the painful details of it, there's an unlisted supply code that hospitals and facilities can bill for PSMA, and usually it's paid at invoice cost. But again, without getting into all the painful details of it, that's been the prior authorization and billing process that we followed.
Okay, just briefly, I've had both surgery and radiation, and have a rising PSMA, but have not had hormone treatment. Is there a way for me to qualify for this test?
Yes. So for those folks who've been treated previously and PSA is climbing, that the first step is they need to have like a telehealth or a face-to-face visit with me so that I can order the study. And so for our out of area patients, we'll just usually set up a telehealth visit like this. And the number to call if interested is area code 239-489-3420. And the patient would then request a PSMA consultation with Dr. Mantz. And we can cover that again at the end.
Okay, or could my oncologist here in Port Charlotte refer me to you?
Sure, yes. We can accept referrals either directly from patients themselves or upon request from a referring physician. And and I'll see patients from both sides.
Okay, thank you. I'll set that up. How booked are you? Is there a scheduling problem?
No, I mean, I think that, I have to spend a week in Chicago for my professional society's annual meeting. I'm on the board of directors and I'm obligated to go there. But after, October 29th and after, I'll be in the area, through the end of the year.
Thank you for your time, sir.
Yeah.
Doctor, is there a PSA level that when this test should be taken that you know like what your PSA level is when you should start to look at this timing?
Yeah, I think, this test begins to demonstrate value in terms of its ability to detect present prostate cancer when the PSA is at a level of 0.2 and above. So, for example, with Axemin, the ability for that test to reliably detect present prostate cancer usually begins at 2.0 and above. This is 0.2, so it's about at a tenth of the value of Axemin that it begins to demonstrate its value. And why that's important is that we have in the medical literature, just a volume of data describing how outcomes, control of disease, is significantly improved at lower PSA levels when recurrence is suspected. That the patient who is diagnosed with a recurrent prostate cancer at a PSA of 0.2 does better than the patient who's diagnosed at 2.0, 4.0, et cetera, et cetera. And so that's why there's really strong interest in the oncology community about this scan. Its ability to detect prostate cancer at very early stages of recurrence is very powerful.
That's a huge change, really, isn't it?
It is. It changes a lot for us. I mean, and so for us, we'll have to rethink some paradigms of how we manage patients. And so, for example, if I see a patient up front and and he has a high Gleason score or a high PSA, but his standard X-ray tests don't demonstrate any cancer outside the prostate, I still have some suspicion that he may be harboring microscopic disease that is below the ability for standard tests to detect. But I could order this scan. And if I happen to see that there's a lymph node that's positive in the pelvis, along with the prostate cancer that's been diagnosed with biopsy, then I'll treat that lymph node and attempt to sterilize it with radiation therapy and hopefully effect cure for that man, rather than waiting for the disease and the lymph node to manifest itself at some later time and then treat it some other way. I think it'll make us we have great tools with surgery and radiation therapy to eradicate prostate cancer. It's not a stubborn cancer to treat if you know where it is. And this test gives us, I think, potentially tremendous insight in being able to focus on where the cancer might be in the patient and eradicate it for maximum effect.
Doctor?
Yes, sir.
Yeah, I realize you're going to focus on PSMA testing, but I have to ask you a question concerning PSA levels. I've always had Quest do my PSA testing, and it would come back 0.1. And I was told by my oncologist and also my radiation oncologist that that's an undetectable level. Well, to me, the last one I did, it came back from Quest, the same lab, 0.04. So either they changed their testing or their sophistication of the testing, but to me, from 0.1 or 0.1 to 0.2 isn't a hell of a lot of difference. So if it's undetectable at 0.1, you know, it's not a far stretch to 0.2. So I'm just, if you have to offer any advice.
Yeah. No. I mean, I get this question a lot from patients, and especially for my patients that are coming from up north, and different labs will use different standards in order to measure PSA, and will have different cutoffs. At which point their standards and their procedures can reliably detect a specific value of PSA. And so some labs will say anything less than 0.1 is too small for us to reliably measure. So we'll say it's undetectable. And for other labs, the number is lower than that. What I tell patients is that far more important than the absolute value of PSA, whatever the number is, if it's 0.1 or 0.04 or whatever, much more important than that is its behavior over time. Provided that the patient goes to the same lab using the same chemicals, the same procedures. And if we see over a period of time that the PSA, even though the number is still quite small, is rising or stable or going down, that information is much more meaningful to me to tell the patient about how well he's doing. And so we'll spend some time talking about standards and procedures in laboratories, but the big thing is that no matter where you go get it done, if you get it done at the same place over a period of time, and if you had multiple tests, the collection of those results is much more important to the patient.
All right, thank you.
Yep. Good. Other questions, folks? Anything else we could address?
I might ask a question if I can, and I'll try to phrase it as best I can. For a gentleman who is up in upstate New York, and he is in fairly constant contact with me about his scenario, and he's seeking advice from medical authorities all over the place, including several doctors here in Florida. And he's been to Sloan Kettering, so he's really looking at strong places for advice. And his PSA, he's had his prostate removed. His PSA is currently gone from 14 to 17 in about 6 weeks. So he's seeing this rise, and he's very concerned about it. He doesn't know quite what to do. He thinks he's having a PSMA test in about 10 days. And I said, well, can you find out for sure? Because you were the doctor to ask about this. And he's supposed to be on the call today. I haven't seen him yet. But I just wondered, I think he's going to get a PSMA test on 2 weeks from now, but he can't really identify it. But is there some other test that he might be facing that?
No, it sounds likely. And, if he's up in New York, and if he's at a place such as Memorial, Sloan Kettering, or Roswell Park in Buffalo, if he's from upstate New York, I mean, those are going to be the facilities in that state that will be able to, have access to the material and be able to perform PSMA scanning. To me, it sounds as though that's what he's been scheduled for. So
is that something that would be helpful to him? I mean, does that sound like a logical step for him?
Yes, no, very much. I mean, so for that patient, and if he's not been started on hormone therapy already.
Right.
That if he undergoes a PSMA scan, and I have a few patients right now just like this, rising PSA after surgery, previous types of x-rays have never been able to detect the source of PSA. The man doesn't want hormone therapy on a presumptive basis. He wants to know that there's cancer present before he makes a commitment to any type of treatment. That we get a PSMA scan now, and if it shows some focus of activity somewhere in the body, but it's limited, if it's just limited to the lymph nodes, for example, then I can have a reasonable discussion with that patient about his treatment options. And one option might be, okay, we have some evidence here that there's cancer active in the body, the scan detected it. You can commit to hormone therapy now, or as an alternative, you can have hormone therapy, plus if the cancer seems to be limited in just one part of the body, it's not distributed over many different lymph nodes or throughout the body, that there is evidence that adding radiation therapy to that small area of recurrent disease augments the effect of hormone therapy and helps the patient live longer, perhaps, than if he just had hormone therapy by itself. That too is an option, but without getting into all the all the permutations that are possible here. That's just an example of how the scan, if done, may help inform a very good clinical decision for the patient.
Yeah, I think that answer is going to be very helpful for him. It
Yeah,
really clarifies where he is. Yeah. Thank you.
Yeah, I think so. Great. All right. Well, if you folks would like, please let me run through some slides for about 10 minutes and we can follow up with any questions at the back end. So David, I need to take control. I'm going to hit share screen, but it says host disabled participant screen sharing. If there's a way for you to unblock me.
I just you the co-host,
Oh,
and I think that helps.
here we go. I did something. So it looks like it's working. All right.
Yeah.
I think you can see me here. Yes?
Yes.
Okay, and let me figure out presentation. Nope. What I'm going to do is, here we go, from beginning. Yeah, my buttons are blocked by the Zoom buttons, so.
Oh, geez.
Yeah, that's okay. I had to guess where it was, but I figured it out. So, yeah, so folks, we'll kick off here and start moving through the slides quickly. And again, our topic today is PSMA PET imaging for prostate cancer. And again, to repeat, PSMA is this acronym for prostate-specific membrane antigen. And PSMA, as a unique marker for prostate cells, can be used with the right imaging tools to detect prostate cancer recurrence for those men who've been treated previously with surgery and/or radiation therapy. And importantly, I think increasingly importantly, to detect metastatic disease, that is cancer that has already spread outside the prostate, for patients who are newly diagnosed with prostate cancer but have a higher risk cancer. Those patients would be patients who have a Gleason score of 8, 9, or 10, or a PSA above 15 or 20 at the time that they're diagnosed. And the prostate cancer cell on the right produces these very specific proteins and places them at the membrane, at the surface of the cell. And these unique proteins can be bound to by a molecule that is engineered to fit only like a lock and key to those surface proteins. That molecule, which is indicated there to the left as PSMA targeting ligand, can be bound to a radioactive element. In the case of PSMA, it's an isotope of fluorine, F18, that is slightly radioactive, can be bound to that molecule. And when the molecule then binds to the protein on the surface, the F18, which is the radioactive element, will produce a radioactive signal, a gamma ray, that will then exit out of the patient and will be picked up by a hardware detector on the PET scanner. And that hardware detector then unscrambles that image, that signal, and translates it into data that can be used to produce a three-dimensional image. And so the PET scanner looks very much like a CT scanner. It's a large machine that looks like a big donut, and it's not an MRI that encases the person entirely. And for the most part, patients are going to be very comfortable going through a PET scan. PET stands for positron emission tomography, and it creates computerized images of chemical changes that take place in the body. And the chemical change that we're talking about today is the binding of the PSMA molecule onto PSMA. And so patients are given an injection of a radioactive substance that will bind to tumor cells. The patient lies still for about 30 to 60 minutes while the substance circulates throughout the body. And then we'll take the patient into the room where the PET scanner is and conduct a scan over the next typically 15 to 30 minutes, not 60 minutes. And the PET scanner will detect the distribution of this radioactive substance in the body. The PET scanner also has built into it a CT scanner, which produces images in 3 dimensions of the sizes and shapes of things in the body, lymph nodes and organs and tumors and so forth. And what a PET CT scanner will do then is overlay these areas of activity onto the CT scan. And so you can sort of window back and forth between these two sets of images and see a lymph node or see a bone or a questionable tumor on the CT scan and determine if it lights up or it doesn't light up. If it lights up, then there's a high degree of suspicion that that's cancerous. And so the current status of PSMA scanning, the specific substance that's used is indicated there. The brand name for it is something called Pylarify, piflufolastat F18 is the generic name. And it was FDA approved in May of 2021. And we can use it to diagnose patients just diagnosed with prostate cancer for any possibility of metastatic disease. These are the high-risk patients that we had talked about, or for restaging patients with suspected prostate cancer recurrence after prior surgery or radiation therapy. So what value does this scan bring to the patient? Well, high-risk patients undergoing additional imaging with conventional CT scan or a bone scan in the present day encounter some limitations from these scans. For one, the conventional CT scan or bone scan is not very good at detecting very small tumors. And for another, bone scans will detect bone damage completely unrelated to cancer, old fractures, arthritis, and so on, and will result in a high rate of false positives that may result in further but unnecessary additional testing. So what we hope is that a more specific scan, like a PSMA scan, will replace CT imaging and bone scan imaging and will give us not just more accurate information about the patient, but will also cut down on the need for follow-up x-rays and biopsies, hunting down red herrings that these other scans will show falsely positive. And so here's an image of one of my patients who had a higher risk prostate cancer diagnosis. Was diagnosed with a Gleason score 9 cancer. His PSA was 18. And so saw him, I don't know, 3 or 4 weeks ago and convinced him to have a PSMA scan so that we can take a look at the body and make sure that there aren't any other areas that light up. And when you get a PSMA scan or any type of PET scan, certain areas in the body will light up where the solution is filtered and eventually passed out of the body. So the liver, which is that yellow-green thing that you see on the right, on the left of the patient, is the liver. It absorbs a significant amount of the solution and breaks it down before clearing it out of the body. The kidneys and the bladder, which show up as red, filter this stuff, put it into the urine, and then allow for the person to excrete it out of his body in a short matter of time. So we look at those normal organs and we just dismiss them. We say that, whatever shows up there doesn't really count. But anything else that shows up does count. And so there are a few areas that have arrows drawn to the cross sections where we can see them a little bit more clearly that light up. And those areas that light up are lymph nodes. Prostate cancer, not as a rule, but usually will spread to the lymph nodes first before it travels to the bones. And on image B, we see a lymph node that is in the chest, just underneath the windpipe that lights up. And on image C, we see a couple of lymph nodes next to the large blood vessels that go down the pelvis that also light up. And I then ordered a biopsy of one of the larger lymph node on image C, and it proved to be positive for prostate cancer. And it changed this patient's management. Rather than put him through 2 months of radiation therapy and hormone therapy, I treated him with hormone therapy alone. This is a patient for whom the cancer has already traveled, and to treat the prostate by itself is not going to be something of real value for this patient. Here's an example of a patient who had surgery and was referred to me because his PSA was going up, and obtained a PSMA scan to take a look at the body to see where there might be a collection of prostate cancer cells responsible for his PSA. His PSA was 0.7 at the time that I'd seen him, and had been low for about 4 or 5 years after surgery, was effectively 0, but then began to rise earlier this year. And so the PSMA scan was done. The CT scan part of this PET scan is on the left, and the PSMA PET images are overlaid on the right. And there's a gray little ball seen that's circled in green, which is resting behind the rectum. That's that round organ in front of it. The bladder is in front of that too. That small lymph node lit up very brightly, as pointed to by the arrow on PSMA scanning. And again, biopsy was done, and that was found to be positive for prostate cancer. Now I'm treating this patient with radiation therapy directed to that lymph node. I'm not treating anything else, not the area where the surgery was done, not any other lymph node. I've been so informed that here's where the cancer is. And so I'm going to direct my treatment to it. And so with that, I hope to minimize what toxicity I can produce to the patient, because I'm limiting my scope of what I'm treating, and maximize the effectiveness of that treatment because I know I'm treating where there is active cancer.
What will you use, doctor, to obliterate that particular?
And so there's a method of treatment called stereotactic radiation therapy, which for small tumors in the body, such as this, will compress a complete course of radiation therapy down to 5 visits instead of the usual 6 weeks or 8 weeks or 9 weeks. And if I have a small enough tumor and I have technology that allows me to focus very sharply on a small tumor and deliver a much greater dose of radiation per day safely than I can with conventional radiation therapy equipment, then that's the treatment of choice. And it works great. That it'll be more than sufficient to sterilize whatever cancer is present in that lymph node.
Mhm.
And so that treatment takes about a week to complete.
Thank you.
Yes. And then lastly, here's another fellow who had surgery, and PSA was rising. His PSA was, I forgot what it was, probably 1.0, something like that I saw. And here is his PSMA scan. You can see these white, rectangular streaks on the image. Those are the surgical clips that the surgeon had placed when he removed the prostate and had clamp down blood vessels to stop them from bleeding. And in the midst of all those clips was a little bit of residual tissue, the seminal vesicle that usually the surgeons will leave behind after doing a prostatectomy. But that can sometimes be a source for recurrent cancer. And it was in this case. So this little gland that comes right off the back of the prostate called the seminal vesicle, for this patient, had some spread of his prostate cancer onto it. And given enough time after surgery, the cancer grew where it was producing detectable PSA. I ordered the PSMA scan, and that spot lit up very brightly. Performed a biopsy of that area, and it did confirm prostate cancer. So now he's getting treated to that seminal vesicle with radiation therapy. And the intent again is to sterilize it and bring the PSA back down to 0. And then I think, oh, this is the last one, I think then. This is a fellow who was treated with, I'm sorry, someone spoke up. Is there a question, folks? Oh. Lastly, a patient who was treated with hormone therapy and radiation therapy some years ago. PSA began to climb and was about, I think, 7 or 8 by the time I saw the patient. Ordered a PSMA scan. He had one focus of disease, and that was in a vertebral body. This is a small bone in his thoracic spine in the back. And, looking on the right, the CT image really doesn't show you anything. But on the left, the PSMA scan shows very brightly just a tiny little dot of metastasis responsible for producing his excess PSA. And so here's a patient for whom I'll also treat with a pinpoint form of radiation therapy to eradicate that lesion. I'm also treating him with hormone therapy because once the cancer spreads to the bones, it has a predilection for spreading to other bones unless you get out in front of it. And so hormone therapy is the way to treat the rest of the body effectively for that purpose. And so there are a couple of studies that have been published advocating for the use and value of PSMA scans. The Lancet, which is the most esteemed medical journal in our field, published in 2020 a study that compared PSMA scanning for high-risk prostate cancer patients against standard of care imaging, including CT scans and bone scans. And the result was that PSMA scanning was almost a third more accurate and sensitive in detecting cancers above these other types of scans. And PSMA scans were also compared to Axeman scan, which they intend to replace someday. And there was a randomized study comparing about 50 patients, all of whom received both Axeman scans and PSMA scans. And the results were compared between these two scans for these patients. And significantly, and I think it's in the middle of the slide, 37% of patients were found to have a positive PSMA scan, but a negative Axeman scan, meaning that the ability of PSMA to detect cancer was about a third greater, again, than Axeman for these patients. Very few patients had a positive Axeman scan, only 2%, but a negative PSMA scan. So looking at it the other way around, Axeman was not at all more sensitive than PSMA. And for these patients, the distribution of detection was, about 20% in the prostate bed after surgery, 37% in the lymph nodes, and about 8% in the skeleton. And these were all patients with relatively low PSAs, between 0.2 and 2.0 after their surgery. So at the present time, we recommend PSMA scans for those patients who are suspected to have prostate cancer recurrence, and it seems to be effective for PSA levels as low as 0.2 and above. And I think I included it, there it is. And so NCCN is a third-party national expert consensus group that rules on the best standards of managing prostate cancer among all other cancers. And will publish guidelines that are well recognized among all oncologists. We use these all the time in order to, backstop decisions that we make for patients. And this body will include, plenty of smart people who know the medical literature extremely well and will opine on what are the best clinical pathways to follow for certain patients. And they have included now PSMA imaging for restaging patients who are suspected to have recurrent prostate cancer, and to be considered for those patients with high-risk prostate cancer diagnosis in order to rule out any metastases that have remained undetected by standard imaging such as CAT scans and bone scans. And I think that's it. I'm just going to go back to.
I have a question for you, Doctor.
Yes, sir.
Does the PSMA scan pick up other than prostate cancers?
Yeah, the fast answer is no. The more complete answer is that there are rare cells in the body that will also produce the PSMA protein and express it on their cell surface, but will do so in such a tiny concentration that it's difficult to imagine that it would be detected by something like a PSMA scan. But let's just say, without equivocating, that the fast answer is no.
Okay. Any other questions, guys?
Doctor, at what point after, let's say you do a PSMA scan and you develop a procedure for dealing with the cancer, which may have metastasized, at what point would you order another scan to see how effective your treatment would be?
So thereafter, I still depend on PSA, the blood test, to tell me how well the person's doing. And if I've treated a patient after a PSMA scan has directed that treatment and the PSA goes down, I'm satisfied with that. And I would only consider repeating the scan if the PSA begins to misbehave again and is turning upward, and I need an answer as to why that's happening. Yeah.
All right, thank you.
Anything else, guys? You can't ask in an hour. You'll think of questions, I'm sure. But you can ask me and I'll relate them to Dr. Mantz. But what a great presentation. Yes, go ahead, Ben.
Yeah, Doctor, I have a question. It's not regarding PSMA, but I've been to a couple of urologists and a radiation oncologist. Now I have a radiation oncologist who started me on Casodex and asked about genetic tests, and he sent away to see what the cancer cells, not a family of genetics, but genetics. And I just nobody mentioned anything about doing Casodex and the NAAC or whatever, because I have favorable intermediate, it said no hormone therapy would be required. So I just find it, is it odd that he would start me on this Casodex for a month before the results of the genetics come back?
Yeah, no, not so strange. I think, if you would mind sharing a little bit more, what Gleason score did you have?
3+4s, couple of 3+4s and 2 3+3s.
And what was the PSA level just before diagnosis?
4.0.
4.0. Okay. So so he's using Casodex as a temporizing measure, meaning this, that he sent off a genetics assay of the biopsy material. And what that test will do is we'll look for mutations in that prostate cancer tissue that can be predictive of how well that man would do, what the risk of this cancer is of ultimately traveling to other places in the body. And ultimately, the physician will get back a report with a risk score, on the basis of this analysis of mutations. And the risk score will give the patient some information that if there's no hormone therapy given, for example, that the risk of this cancer spreading is 1%, 30%, 50%. And from that information, the physician can make a recommendation that the patient needs to commit to a hormone shot or not. But he's hedging his bets a little bit, and he's starting you on Casodex, which for the most part is harmless. And it does have an anti-testosterone effect. It blocks the effect of testosterone on prostate cancer cells in the body. But without the hot flashes and diminishing testosterone production the way that hormone shots do. And if the test result comes back favorable, if it's a low risk score, he'll tell you to stop Casodex, and then he might start radiation therapy at that time. But if the risk score comes back high, then he will tell you, well, I've already started treating this with a method of hormone therapy. Now let's do the shot to complete that treatment and then start the radiation therapy. And it's usually, one of those two directions that the patient will go, waiting for the results of this test. And some of us will start patients on Casodex as a temporizing measure, just in case. I usually don't, because I don't have any evidence that, that's a benefit to the patient. There's no randomized data that suggests that, you have to do that, or you risk that the patient suffers a recurrence at a greater rate later. But it's essentially a harmless medicine. It's just the bother for the person to take it while he's waiting for the results.
Okay. Thank you very much.
And with what Sylvester did with me.
Let me ask one quick question. Do you have any doctors in your practice that perform transperineal biopsies?
Yes, I do, but not as a routine. Meaning that we have urologists that will not go through the transrectal route to obtain a biopsy, and do have skill in going through the perineum in order to obtain tissue. But for the most part, they don't prefer, in that the tissue needs to pass through the biopsy needle, and the specimen needs to pass through more tissue planes, and there's a risk of disrupting the tissue specimen that way. Rather than going through the rectum, which is a more direct shot into the prostate, and the tissue can be secured with greater confidence without it trailing through other tissue. But for the patient who is, absent a rectum, or who has a history of rectal complications such as fissures and fistulas and so on, the urologist will take a transperineal route. It's just not, they might do, 500 transrectal biopsies before they do one transperineal biopsy. It's hard to find a urologist who prefers that in general. I can tell you in Europe, that's what the urologist will do as a general rule. They won't go.
Yeah, I know.
Yeah. And,
and then there's also the new one, the precision point, where they put in 2 hollow needles, and then they just keep taking this multiple samples through those. So you don't go through other tissue.
That's right. And so
but I don't know of anybody that does it here.
Yeah, no. That's right. I mean, and that's another method that's been developed to try to, obtain tissue through the transperineal route, but not cause the disruption of having to pull that biopsy needle through all those tissues. But
right.
Yeah, but it's to my knowledge, folks, it's going to be hard to find a U.S. urologist that has much experience with either approach.
Yeah. Well, there's a couple like in Virginia, but there's none that I know of in Florida.
Yeah, it's hard to find these.
Well, actually, they have it at Mayo in Florida, but
yeah,
that's kind of far too. So.
Yeah, no, that's right, and it's right, and sometimes it's the resident who practices on the patient. I mean, you want to have the person who's done it for 20 years,
On the transperineal biopsies that your urologists do, can they also do the targeting with it, like with the UroNav or something?
Yeah, and
or
so,
no?
right, I mean, we haven't touched on this, but, we were the first, we brought in UroNav into Florida about 9 years ago. We were in practice and to bring it in, and we distributed it amongst our urologists, and they love it. It tells them exactly, based on the MRI, that the patient has before biopsy, where the needle should go. It's not just a blind random. And there's a little bit of a learning curve that the urologist needs to get past, but once he does that, it's a fantastic tool, and they love it. The yield, the ability to diagnose prostate cancer, doubles effectively with the UroNav system. Great tool.
And can they do the transperineal UroNav? Because you have to have that extra adapter.
Yeah, that's right. I mean, and so they have a transperineal option, but the urologist will still use the transrectal route. And because, again, they're more comfortable passing the needle from that direction. And, we'll use, the needle guide that comes for the transrectal procedure when done with UroNav. And, and I have my own preferences, but, I'm loath to step on the toes of the urologists who are performing the biopsies because it's their work. And whatever our preferences may be, you trust your urologist who's done this 20,000 times to do it well. And they do.
I've had 2 biopsies done. One was rectal, one was perineal, and the doctor here in Sarasota was Dr. Barzell, who did the transperineal with the MRI imaging going along there, and they were equally as uncomfortable, but he preferred the transperineal because he thought he'd get closer to the sample would be closer to obtain what he needed. So it is available here in Sarasota.
Yeah. I mean, in Winston, who's Winston Barzell, he's highly esteemed. He's sort of a giant among urologists. He's been around, for a long time, and he's been responsible for some key innovations in the field. I mean, he's not one to brag about it, but he really is.
He'll brag about it, no? Don't get that wrong.
If you push him, he'll talk to you about it. But if you're just sitting there and you never bring it up, he probably won't. But I think Winston, if in the Sarasota area, is a good urologist to see.
Yeah, if you want to get into transperineal, then he's the guy to go to, I would think.
Yeah.
Well, guys, thank you so much, everybody, particularly Dr. Mantz. My gosh. That's
Thank you, Dr. Mantz.
the most informative sessions we've had.
Thank you, Doctor.
Yeah, no, quite welcome, guys. And listen, please reach back, to David with any questions, and however I can help, be happy to do it. Okay.
Thank you.
Thank you.
Everybody.
Take care now. Bye-bye.
Thank you.
We're outside.
And thank you, David.
Me.